Perfect. Okay, so this first case that we're going to go through, it's quite an interesting one, but I'm going to give you the history. Due to the fact everything has to be anonymised, you'll notice that I haven't put any dates in. We're just going to go through the days instead. But if anything needs to be clarified, just let me know. Okay, so this is the presenting history so far. This is 34-year-old primate. She's 38 plus 2 gestation. She's induction of labour on an antenatal ward for gestational diabetes and PIH and treated with these medications. As I'm aware, the GDM was quite under controlled on 500 BD. She had an ultra scan at 37 weeks. Everything was otherwise normal apart from mild poly, and baby's weight was on the 15th centile. But this was quite normal for this baby following its curve anyway. Okay. So her induction of labour, she started with dilapan, and then the second day it was removed and they inserted Propes. Propes was removed 24 hours later, and then she had Prostin 2 milligrams that was given. Later that evening, around 6-7 hours afterwards, she then shrommed. It was clear liquor, and they examined her because she requested analgesia at just after midnight, and she was 4 centimetres. So his plan was to transfer to delivery suite. Okay, so she was transferred to delivery suite, and this is her first CTG. At 1 o'clock, so just before, she was given pethidine. And this is the CTG. Has anyone got any comments so far on the CTG?
Do we have any CTG before induction or on like the first CTG during induction?
So the first, not on me, but for the first CTG, baseline was 140. Everything was fine, accelerative, no decels, mild contractions throughout. But otherwise, it was normal antenatal CTGs. But baseline was 140. Yes. Okay. So this is the first CTG. I'd otherwise say that it's quite a normal CTG. She's just had pethidine.
So we're happy to move on.
Yeah, happy to carry on. Has anyone got any objections? Anyone would do anything differently?
Continue.
Continue. Okay. So then the CTG continues. At the start of this CTG, she was involuntary pushing. So the midwife thought, okay, let me examine, see what's happening. So she examined, she was then 9 centimetres. Presenting part was at spines. Anyone have anything they want to comment?
Is the CTG moving? I can't see the CTG. It's like constant only. Do you have another CTG?
This is the next one. It's very similar to the first one. Can you see this one? Times 0202 on here.
Okay.
Yeah. I'll move on. Binny, can you see this next one?
Yes, I can see.
Yeah, we can see. Yeah.
Okay. So this is the next one. So here she had her blood pressure taken as normal in labour. Blood pressure was 164 over 102. So treated with her normal Levitolol. She was taking Entonox at the time. Some question whether it was taken during a contraction, but the CTG continues. Is everyone happy to continue? Will anyone have any objections or want to discuss anything so far?
Continue.
Sorsha, can you tell us again, when she examined her, she was how many centimeters?
She was 9 centimetres about an hour ago. She was 9 centimetres.
An hour ago. Okay, yeah.
Okay, she's shrunk, glycol, everything's fine. Just blood pressure raised now. All right, so we'll continue. So CTG continues. Now we put on the maternal pulse probe, so we can see maternal pulse is around 70 or 80. CTG continues, contracting 3 and 10 roughly, 2 to 3 and 10 in coordinate. But plan was to start actively pushing at past. So the midwife got her up just after, obviously, where the CTG ends and says, okay, let's try and pass urine because she hasn't passed urine for a few hours. So she gets her up onto the toilet. She doesn't manage to pass urine, but she's involuntary pushing on the toilet. So Midwife says, okay, let's get you back onto the CTG. So pops back on the CTG here. So doing in and out catheter, she drains 70 mils. CTG continues.
When she ruptured the membrane, you said the liquor was clear?
Yeah, clear liquor still. No
Yeah.
offensive smell. Observations have been stable, apart from the blood pressure has been slightly raised, but she's no PIH on the beta-lol, BD. So CTG continues. Towards the end of the previous CTG, there was quite a bit of loss of contact, so they thought, okay, let's put a fetal scalp electrode on. So FSC applied. Maternal
Well done.
pulse remains the same. Yeah. Anyone got any comments? Everyone's still happy to continue with normal care? No one's running to theatre?
No, we can we can continue.
Okay, so there's still good variability. Baselines remain the same, hasn't it? We've got some decelerations, but there's good variability within them. So we'll continue. She'll start pushing, hopefully in the next half an hour.
So, did we examine to see that she's fully?
Yeah, so yeah, we're just there. 0420.
Okay.
Examine. She's she's at spines, fully, +1 of caput noted. Query position OT for baby. So they thought, okay, let's actively start pushing now. So they started actively pushing around 25 past here, just before. Okay, CSG continues. Anyone anticipating what's going to happen next? So if we were in this room at 4 o'clock in the morning, I start pushing, what am I anticipating is going to happen? Or what could I think might happen?
She will have more variable decelerations, and then we might end up in a instrumental delivery at some point. But at the moment, we are happy.
Yeah. So if we are having decelerations like this, it's fine. We're just going to anticipate they might get wider and deeper. So we're anticipating that the CTG may not look necessarily perfect, but will continue. CTG continues. So she's pushing actively. Vertex is now visible at the start of this CTG trace here. And what usually happens is we tend to get a bit task orientated. So vertex is visible, push, 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 push. We do another in and out catheter and we drain 200 mils, which probably help the situation. And then baby's born, head delivers at 05:15 here. And then baby delivered at 05:16. Spontaneous vaginal delivery. Okay. Everyone happy with the CTG trace?
Yeah.
Yeah. So how are we anticipating this baby's going to come out? What's reassuring during this case that's making me think, okay, baby's going to come out screaming, or baby's not, or baby?
Baseline and variability.
Yeah,
variability is.
Sorry?
Variability is very good. That is the best thing.
Yeah, so variability is reassuring throughout. Yes, we're having those wider, deeper decelerations, but we know we're putting more stress on this fetus throughout second stage. We also think to ourselves, they are recovering. Yes, they're slower to recover, but we know actually we're not going to put this fetus through a long period. We can see vertex and actually delivery is imminent. Okay, so baby was born at GARS 8, 10 and 10, mainly 8 because of the tone. They think mainly because of the pething that she had 4 hours previously. Baby stayed with mum, no concerns whatsoever. Okay, baby was noted to be slightly below gestational weight on the 7th centile, which I think some people were quite surprised at because of the fact that this is a GDM baby, but actually this mum also had PIH as well. But if we think to ourselves, this baby, if we look back on the case as well, this baby we could see actually showed signs that we are progressing quite quickly, and actually this baby's got probably less reserves than usual because how quickly this baby did start having those wide, deep decelerations. But another reassuring thing is that we had clear light all throughout. If this was, say, a meconium or a choreo baby, then we're more likely to have our reserves about this baby, thinking that there's already a stress on top. Okay. Has anyone got any questions about that case?
If the baby was on the 7th centile and we knew, why no cord gases were done?
We didn't know it was on the 7th centile. We didn't. That was just at birth. It was on the 15th centile on the scan the week before.
All right. Okay. Yeah.
Baby was anticipated 2.6 kilos the week before, and that was on the 15th centile. So I think actually it was smaller than what we thought, but within the scan results, it was normal. Does that make sense? Probably
Yeah.
not.
Yeah. No, it makes. Thank you.
Okay. So now I'm going to move on to the second case that we've got.
Can I just have one comment?
Yeah.
Can you just give feedback to the midwife or the doctor who put 6 Dilapan for this poor lady and wasted time, that not to put such things? Can they not start propers? Because it must be Bishop score of 0. But I really appreciate whoever put 6 Dilapan should be given a OBE.
Okay. Yeah, that's fine. I think it's something that I'll bring back to Hannah as well, because I think we're trying to use dilapan a little bit more. I think because she had some risk factors, it might have been that, but I'll definitely bring it back to Hannah. Okay. Anyone else got anything before we move on to the next case?
No, I think it was very well managed, to be honest. Very good.
Yeah, it was a positive case actually. It's sorry.
Very good. And this is the importance of this presenting also well managed cases as well as difficult cases. So that's nicely done. Thank you, Sorj.
That's okay. Okay, so we'll move on to the second case that we've got. So the second case here, bear with me, I'm just going to make it bigger. So this is the presenting history. She's 30 years old, BMI of 19. She's otherwise low risk pregnancy and her normal scan at 20 weeks, but otherwise NAD, the centre was high. Otherwise unremarkable pregnancy. She arrived in triage contracting and she was examined at 2:30. She was 6 centimetres, and because she was low risk, she went to birth centre. Now, throughout the birth centre, she had intermittent auscultation, and the fetal heart was documented between 130 and 140 beats per minute, which was normal for this lady. At 4 o'clock, she then started involuntary pushing. She was then examined at 8 centimetres with blood-stained Lycor on Schromm on examination. They continued. She was examined at 6 o'clock in the morning. She was 9 centimetre, anterior lip noted, but very, very thin. But she was involuntary pushing throughout this as well. She was then fully at 9 o'clock, and because obviously she was still fully with minimal progression, plan was to transfer to labour ward. What we anticipate in the CTG is going to look like. She's low risk, no risk factors.
Yeah, my question here, Sorsha, which is maybe you can shed some light on. She's fully for 1 hour for transfer to labor ward. I don't understand this. Whether they felt that the head was high, or what do you mean?
So she started pushing. Sorry, that wasn't clear. So she's fully for an hour at 9 o'clock, and she was pushing, but there was minimal progression. And they transferred to labour because they thought she needed probably a lift out to come out. So it was more the fact she was fully in pushing for an hour, rather than just fully an hour. Sorry, that was my fault.
So what was the station here?
It was at -1 to spines.
Okay, that makes sense. Okay, yeah.
Okay. So we'll go on to the CTG. So she commenced CTG monitoring when she came over to labour ward. So baseline still remains sort of very similar, 130, 140 here. Quite a lot of loss of contact. We are aware of difficulties at second stage when auscultating the fetal heart. But we know there is some baseline here, which is reassuring. Also looks like quite good variability as well. So even though we've got a lot of loss of contact here, we have got reassuring signs that actually this is a quite stable baby. We've got maternal pulse here, and I do like these new CTGs because they show beautifully what maternal pulse looks like when the woman is pushing and actually when she's uncomfortable during these contractions. So you see these lovely peaks that we have towards the end of the CTG here. So we actually know that she's quite stable as well. Has anyone got any other comments on this CTG here?
Maybe I would have been more lenient to put an FSC, maybe.
Yeah. So
Yeah.
yeah, definitely advisable to put an FSC on. Anyone else worried about the CTG, or they think they're concerned, or they'd escalate to the registrar? Obviously, you want the registrar to review anyway because of the length of time we've been fully for. So we're hitting around sort of 3 hours now, coming up to 11 o'clock.
I probably would, just because of the loss of contact.
Oh, someone talking.
It was Millie. I was just saying I probably would escalate just because of the loss of contact.
Okay. Yeah. So it's anticipating, that we put an FSC on. Perfect. So we'll carry on the CTG here. So plan here, the registrar saw the woman, she didn't think she was contracting regularly enough. So syntocinon was started at 12 mils with the anticipation that potentially we could have a instrumental delivery. They wanted to start a litre of Hartmann's as well over the next hour.
Sorry, Sorsha. So when the registrar examined, where was the head position?
It was at spines at this point. So it's come down a little bit from previously. So it's at spines now. So just on the previous one, she was at spines towards the end of that. She had an examination, plan for syntocinon, litre of Hartmann's, and in the next sort of 10-15 minutes, instrumental.
Okay.
Okay.
Is this acceleration is when the examination was?
Just before here, I think the loss of contact just at the start of this trace. That's where the examination occurred.
Okay, so when the examination happened and there is some fetal scalp stimulation, there was no acceleration?
No, not
Okay.
initially, no.
Okay.
So then here, syntocinon started at 11:18. So here, the cup was applied. So you see baby's reacting here, which is reassuring. So kiwi cup in the room, and then one pull, and vertex is advancing. Head was then delivered at 11:26, and then baby delivered at 11:27. Okay. How are we anticipating? So it was blood stained Lycor earlier. So no risk factors, meconium or choreo. Maternal observations have been stable. The whole clinical picture, mum was otherwise low risk, apart from when she became fully. How are we expecting the baby to come?
Baby is flat.
Baby's. Why do we think baby?
Mum's
Sorry?
quite a
Baby
while.
needs resuscitation, I'm guessing.
Why?
I don't know. The CTG is not the best CTG to see what is happening. Yes, overall fine. There is variability, but something is telling me baby will need resuscitation.
Okay. Okay. Anyone else got any comments?
I was just saying that mum had been pushing for an hour previously before getting onto labour ward, so baby may need a bit of help, just because it was prolonged.
Okay. Fine. Anyone think any differently?
I think baby will be fine. I think it will come with gases of like near the 7.2. So, so it's might need some inflation breath, but
Yeah, some sort of resuscitation. 7.3.
It's like a game now. Okay. Why would she need core gases? Because it's an instrumental?
And also the CTG, patient is pushing for 3 hours. CTG is not the best CTG recordable. If you go to court, at least we have gases, then we are fine.
Okay.
and instrumental is a must, definitely.
There are 3 things.
Okay. So there was no core gases taken at this delivery. Baby head up girls are 9, 10, and 10. and absolutely fine, didn't require any resuscitation, and baby and mum were discharged home the next day. Okay.
Very good.
I've got to start with good cases. Okay. Now, the reason why I chose these cases is because it's really, really important to look at that whole clinical picture and to look at actually what's going on. There was no further risk factors here. If we, like I said, mentioned before, if there was meconium, if there was scar there, feedback, etc., the risk factors have such a big impact on the whole clinical picture because actually our interpretation, our management would change based on those. So actually this was quite a low risk woman anyway, and yes, she was fully for a long period of time, and it probably has done no good for her pelvic floor, but the fetus in this sense, actually there's reassuring features within these CTGs. There's not a flat CTG, there's been no rise in the baseline on the CTG, and actually there's reassuring features throughout. Has anyone got any questions of either case?
No, both are well managed. Yeah.
Yeah, happy with both. Okay, so that is it